Imagine you have just finished running a marathon. You're completely depleted, your muscles are just, actively trembling, and frankly, you have absolutely nothing left in the tank.
Right. You're totally exhausting.
Exactly. Now imagine immediately undergoing major abdominal surgery right there at the finish line.
Oh, wow.
Yeah, and then as you are being wheeled into a recovery room, someone hands you a fragile newborn baby and basically says, "Here you go. You need to keep this tiny human alive around the clock now. Good luck."
Sounds completely overwhelming.
It is. And how long would you logically expect that recovery to take? Because society, celebrity culture, and honestly, a lot of workplace policies, they tell you it takes about 6 weeks.
Well, yeah, but biology tells a completely different, much more demanding story.
Welcome to today's deep dive. We are looking at a really fascinating stack of medical literature today.
We really are. We've got clinical guidelines from the Royal College of Obstetricians and Gynecologists, some specialized physiotherapy recovery protocols, and even procedural guides from advanced aesthetic gynecology clinics.
Right. And our mission today is to look right past all those cultural myths and just break down the biological reality of postpartum healing.
Because it's so misunderstood.
Totally. We're focusing specifically on a really crucial question, which is, can instrumental birth recovery take longer before treatment? We really want to unpack the intense toll of forceps and vacuum deliveries.
And, figure out why the reality of this recovery timeline forces this mandatory months-long wait before advanced physical treatments can even begin.
Yeah. So what's our overall goal here with these sources?
The overarching goal is to basically synthesize these different medical disciplines. We want to give you a true evidence-based picture of what your body is actually doing during those months.
Which means stripping away the guilt.
Exactly. Stripping away the guilt and those unrealistic expectations surrounding this kind of toxic bounce-back culture. Because the medical data is incredibly clear.
Oh, it really is.
The idea of fully recovering in 6 weeks is not just ambitious, it's physiologically impossible.
I mean, before we even get into the specifics of forceps or lasers, we kind of need to establish a baseline. What does recovery actually mean for an uncomplicated birth?
Right. The baseline itself is pretty intense.
Yeah, because one of the first data points in the clinical guidelines absolutely floored me. At that magical 6-week checkup, where doctors often just give the green light for normal activity, a woman's pelvic floor muscle strength is still reduced by over 50% compared to mid-pregnancy.
Over 50%.
Half of your structural support is just offline.
It really forces a total reframing of what cleared for exercise actually means. And if you look at a surgical birth like a cesarean section, the misconception is even greater.
Because it's not just a scratch.
Right. A C-section isn't just a simple surface cut that you put a bandage over. It is major abdominal surgery that carefully navigates through 6 distinct functional layers of tissue.
Wait, 6 layers?
6 layers. You have the skin, the subcutaneous fat, the fascia, the separated rectus abdominis muscle, the peritoneum, which is that delicate lining of the abdominal cavity, and finally, the thick muscle of the uterus itself.
Man, 6 layers. And I have to imagine each one of those layers heals at a completely different pace.
Oh, totally. It's less of a rigid schedule and more of a complex biological sequence. You literally cannot speed it up.
So even if the outside looks fine.
Exactly. While the surface skin might look closed and cosmetically healed at that 6-week mark, giving this false sense of security, the deeper connective tissue is still in absolute turmoil.
Especially the fascia, right?
Yeah, the fascia in particular. That tough, fibrous glad wrap that holds your internal organs in place, that takes anywhere from 6 to 12 months to actually regain its structural strength and properly remodel its collagen fibers.
So thinking you're fully recovered at 6 weeks just because your incision is closed is kind of like taking a cast off a broken leg and immediately trying to run a marathon.
That is a perfect way to put it.
The plaster is off, the skin looks fine, but the bone underneath is absolutely not ready to bear weight.
That analogy hits the nail on the head. And the underlying mechanism for this long baseline recovery is fascinating, even if you don't have a surgical birth.
Just from the pregnancy itself.
Right, just the sustained physics of carrying a child for 9 months. It actually increases the width of the pelvic floor outlet by 15 to 20%.
Wow. 15 to 20%.
Yeah, the levator hiatus, which is the primary opening in the pelvic floor, it actively widens under the hormonal influence of relaxin and just the sheer mechanical weight of the baby.
So the muscles physically thin out?
They do. And this massive structural change occurs before the trauma of labor even begins.
Meaning your baseline for recovery is already severely compromised before you even hit the delivery room.
Exactly. The architectural integrity of the pelvis has already been fundamentally altered.
Okay, so if a quote-unquote normal recovery takes 6 to 12 months just for deep tissue remodeling, what happens when we introduce a mechanical intervention? Let's talk about instrumental births.
Yeah, this is where the clinical picture becomes highly complex. And it's where the recovery timeline extends significantly.
Right, operative vaginal deliveries. Using forceps or a vacuum extractor. The sources say these account for roughly 10 to 15% of all births.
Yes, and obstetricians typically utilize these tools to shorten the second stage of labor, which is the pushing stage.
Because at that point, the mother is just exhausted.
Completely. If a mother has been pushing for 3 hours, maternal exhaustion has totally set in. Or if the fetal heart rate drops dangerously, the medical team needs to expedite the delivery to prevent severe distress.
Right, and the literature indicates that these instrumental deliveries almost universally require an episiotomy.
Which is a deliberate surgical cut to the perineum.
Yeah, to artificially widen the opening. But looking at the long-term data, the aftermath, especially with forceps, is incredibly severe.
It really is.
The RCOG guidelines show that forceps deliveries are associated with a much higher incidence of pelvic floor muscle denervation.
That's a crucial point.
We aren't just talking about bruised muscles, we're talking about actual physical nerve damage. And that directly leads to the lowest quality of life scores regarding postpartum urinary incontinence.
The neurological impact is profound when you look at the physics of it. I mean, the physical application of the metal forceps blades, combined with the traction required to physically pull the baby out, can severely stretch and compress the pudendal nerve.
And nerves don't really bounce back like rubber bands.
No, nerves do not have much elasticity at all. When you stretch them past their limit alongside the surrounding pelvic floor muscles, the communication pathway between the brain and the muscle just breaks down.
So the muscle doesn't even know it's supposed to be working.
Exactly. For some women, this results in a transient neuropraxia-like, a temporary numbness and weakness that eventually fades. But for others, that denervation leads to lasting stress incontinence and permanently altered bowel function.
Which honestly raises a massive question for me. If forceps cause that much sheer physical trauma-tearing muscles and stretching nerves to the point of denervation, why don't doctors just default to a C-section when labor stalls?
It's a really valid question.
Like, why even risk the forceps and the nerve damage?
It basically comes down to a clinical balancing act between immediate localized risks versus long-term systemic and compounding risks.
What do you mean by compounding risks?
Well, obstetricians aren't just managing the delivery happening in front of them in that exact moment. They have to consider the mother's entire reproductive future. Elective repeat cesarean sections, or ERCS, carry their own catastrophic risks down the line.
Oh, because of the scar tissue.
Precisely. Every single time a surgeon cuts into the uterus, it increases the risk of severe complications for the next pregnancy.
The literature mentioned pelvic adhesions, right?
Yeah, pelvic adhesions, where scar tissue causes internal abdominal organs to literally stick together. That makes any future abdominal surgeries incredibly dangerous.
That sounds awful.
And there's also a significantly higher risk of placenta previa and placenta accreta. This is where the placenta implants over the cervix or grows aggressively, like tree roots, deep into the uterine muscle wall because of the previous scar tissue.
Wait, like tree roots? That sounds like it would cause massive bleeding.
It can. It can cause a catastrophic, life-threatening hemorrhage during the next delivery.
Wow. So it is a highly calculated, albeit kind of terrifying trade-off.
It really is.
The medical team is basically choosing a severe soft tissue and nerve injury right now to successfully prevent a highly complex emergency surgery that could literally jeopardize the mother's life in a future pregnancy.
Ultimately, it is about minimizing mortality. Instrumental births, despite the severe pelvic trauma, are often life-saving alternatives to emergency C-sections late in the second stage of labor.
But that brings us directly to the core focus of our deep dive today. Can instrumental birth recovery take longer before treatment? Because if a pelvic floor injury from forceps is fundamentally a severe soft tissue and nerve injury, why in the world don't we treat it aggressively right out of the gate?
Like a sports injury.
Exactly. If a professional athlete tears a ligament or suffers nerve compression, they are in specialized physical therapy the very next morning. Why is the postpartum protocol so entirely different?
Because the postpartum body is uniquely vulnerable in ways an athlete's body is absolutely not.
How so?
Well, you aren't just dealing with a localized injury. You are managing open wounds, massive systemic fluid shifts, a total crash in hormone levels, and the immense metabolic caloric demands of breastfeeding.
Not to mention recovering from significant blood
Oh,
loss.
right. The body's entire immune and inflammatory response system is working in overdrive, localized purely on basic tissue closure and fighting off deadly infections.
So if you were to add mechanical stress like aggressive physical therapy, deep tissue massage, or high-impact exercise, you aren't actually helping. You're essentially hijacking the body's emergency repair system.
Exactly. You would cause irreversible disruption. You would literally be tearing down the scaffolding before the cement is even dried.
That makes total sense.
The clinical guides emphasize a strict acute healing phase. Before you can even consider high-impact exercise, which, by the way, the latest physiotherapy guidelines explicitly state you must wait a minimum of 12 weeks for certain non-negotiable biological milestones just have to be met.
Yeah, the clinical guides lay out 3 specific milestones that really paint a picture of what the body is doing.
Which one stood out to you?
First, lochia, which is the postpartum uterine discharge consisting of blood, mucus, and uterine tissue. It must stop completely. And that alone usually takes 4 to 6 weeks.
Right, that's step 1.
Second, the cervix, which dilated to 10 centimeters, must fully close back up to protect the uterus from infection.
Crucial for infection control.
And third, any episiotomy stitches or vaginal tears must show complete, stable surface healing.
And during that mandatory waiting period, the physiotherapy is incredibly gentle. It is absolutely not about building muscle mass.
It's more about nerves, right?
Yeah, it's entirely about neural reconnection. Since the pudendal nerve might be stretched or damaged, physiotherapists recommend techniques like piston breathing.
Which sounds like an engine part, but it's really just breathing, right?
It is. It's using the natural movement of the diaphragm as you breathe to slowly, gently remind the brain how to communicate with the core and pelvic floor muscles.
So it's more of a mental connection.
It's a neurological handshake, not a workout. They also utilize advanced tools like pulsed ultrasound.
Okay, I saw that in the notes and had to read it twice. Pulsed ultrasound for an episiotomy wound.
Yeah, it's pretty wild.
How does an ultrasound machine heal a surgical cut?
Well, it utilizes the non-thermal effects of sound waves. Unlike a continuous ultrasound that heats tissue, pulsed ultrasound sends these micro vibrations into the tissue.
Without heating it up.
Right. These tiny mechanical waves help clear out exudates, which are the inflammatory fluids and cellular debris, and relieve pain around the episiotomy stitches without putting any direct mechanical pressure on the raw wound.
That is incredible.
It essentially shakes the debris loose at a cellular level. That promotes tissue repair without disrupting the very delicate, brand new collagen fibers that are trying to knit the skin back together.
Wow. So musculoskeletal and physical rehab must absolutely wait. You just cannot rush the biology.
No, you really can't.
But there was one detail in these clinical guidelines that provided a massive aha moment for me because it is such a stark contrast.
Oh, about the contraception.
Yes. While you can't do a sit-up and you can't go for a run, contraception does not have to wait. The guidelines state that an intrauterine contraception device, an IUC or IUD, can be safely inserted within 10 minutes of the placenta being delivered.
10 minutes.
10 minutes. You are literally still on the delivery bed.
I know, it seems wildly counterintuitive given everything we just discussed about letting the area heal. But from a public health and medical outcomes standpoint, it is a brilliantly effective strategy.
But the mechanics of that are wild to think about. I mean, the uterus is still massive. It just held a baby, and it's actively contracting. Doesn't the device just get pushed right back out?
The clinical data acknowledges that exact risk. Immediate postpartum insertion carries a significantly higher risk of expulsion, the device falling out.
Because of the cramping.
Yes, because the uterus is undergoing involution, which is the intense cramping process of shrinking back to its pre-pregnancy size. However, because the myometrium, the uterine muscle wall, is incredibly thick immediately after childbirth, the risk of the doctor accidentally perforating the uterus with the device is actually much lower.
Okay. But the real reason they do it isn't just about the muscle thickness, is it? It's about the reality of maternal health care.
Exactly right. The 6-month continuation rates for the IUC placed immediately after birth are excellent.
Because the mother already has the device, the medical system knows that society does not support new mothers enough.
No, not at all.
If they wait, she has to somehow find the time, secure childcare, muster the physical energy, and navigate a broken healthcare system to get back to a clinic 6 weeks later when she is severely sleep-deprived and still bleeding.
It secures her reproductive autonomy at the exact moment she is highly engaged with the healthcare system. It totally acknowledges the logistical nightmare of the postpartum period.
So while we are forced to wait on musculoskeletal rehab, we can immediately secure long-term reproductive health.
Precisely.
Okay, let's look at the timeline further down the road. The 4 to 6 week acute phase is finally over. The bleeding has stopped.
The initial healing is done.
Right. The 12-week mark for gentle exercise has passed. Let's say we are now in that 6 to 12-month window. The deep fascial tissues have finally remodeled.
Okay.
But what happens to the woman who reaches month 8 or 9 and realizes her forceps injury isn't healing on its own?
The ones still struggling.
Yeah, the ones who suffered that nerve denervation and are still dealing with daily pain, tissue laxity, or leaking urine every time they cough.
For severe debilitating damage, traditional reconstructive surgery is the standard pathway, and the statistics are actually sobering.
How many are we talking about?
Nearly 400,000 women in the United States undergo surgery for urinary incontinence or pelvic organ prolapse every single year.
400,000 surgeries a year. That is just a staggering number of women suffering in silence.
It's a massive, often entirely silent epidemic of surgical intervention required simply to correct the lingering injuries of childbirth.
They likely feel like their bodies failed them when in reality they survived a massive trauma.
Exactly.
But what about the women who fall in the middle? The ones with mild to moderate incontinence or prolapse who don't necessarily qualify for the operating room, but who are absolutely not living a fully recovered, functional life.
This is where we are seeing the rise of a highly specialized medical field known as aesthetic gynecology.
Okay, I have to stop you there because the name alone is a problem.
It really is.
To a lot of people, myself included, aesthetic gynecology sounds like a cosmetic vanity project. It sounds like predatory marketing designed to make women feel insecure about how their bodies look after birth. Is this just Beverly Hills marketing nonsense?
The nomenclature is terrible. It is a highly unfortunate, misleading name for what is, in reality, advanced medical rehabilitation.
So it's not cosmetic.
Not at all. While the word aesthetic implies cosmetic enhancement or vanity, the clinical data from facilities like Kindred Health detail that these non-surgical treatments are actively, mechanically restoring function.
How do they do that?
They utilize controlled thermal energy, specifically erbium lasers or radiofrequency devices, to treat the internal vaginal tissues.
Well, wait, but how does shining a warm laser inside the body actually fix urinary incontinence caused by metal forceps?
It basically comes down to cellular biology. When you apply highly controlled thermal energy to the vaginal walls, it effectively tricks the body into launching a localized healing cascade.
Like it thinks it's injured again.
Sort of. The heat stimulates fibroblasts, the cells responsible for the structural framework, to produce brand new collagen and elastin fibers. It also promotes a process called angiogenesis.
Wait, angiogenesis, that's the creation of entirely new blood vessels, right?
Precisely. The laser is prompting the body to build a new microscopic vascular network.
Oh, wow.
By thickening, tightening, and revascularizing the vaginal mucosa and the underlying connective tissue, you are quite literally restoring tone and elasticity.
So you're rebuilding it from the inside.
Yes. And most importantly, you are rebuilding the mechanical support hammock that holds the bladder and urethra in their proper anatomical position.
So treatments with names like the bladder support laser or the prolapse laser treatment that we see in the guides, they have nothing to do with how things look cosmetically.
Nothing at all.
They are acting as a physical internal brace rebuilt from the woman's own newly generated collagen to hold the bladder up where the pelvic floor muscles were permanently weakened by the forceps.
It is literal medical rehabilitation for mild prolapse and stress incontinence. But, and this ties our entire deep dive together and answers your core question, the procedural guidelines explicitly state that these advanced laser treatments cannot be performed on women who have recently given birth.
Ah, because you have to respect the biological timeline.
You absolutely have to.
You can't stimulate massive collagen remodeling with a thermal laser if the body's immune system is still in the acute phase of trying to close a surgical episiotomy wound, fight off infection, and stop the uterine bleeding.
The timing is critical. These laser treatments require 2 to 3 separate sessions. They take weeks to show full results as the new collagen actually grows, and the structural effects last up to 18 months.
So you need a stable foundation first.
You have to wait for the intense postpartum inflammatory response to completely settle.
Yeah.
You have to wait for the baseline tissue to stabilize, which, as we established with the fascia, takes 6 to 12 months. Only then can a clinician accurately assess the residual, permanent damage and safely apply these advanced thermal therapies to rebuild the tissue.
It is just a phenomenal biological journey. When we step back and look at what we've covered today, the answer is undeniably clear.
Yes, recovering from an instrumental birth takes significantly longer before you can even begin advanced treatments.
The profound depth of the nerve stretching, the tissue tearing, and the fascial trauma, it just demands time.
It really does.
I mean, we started by dismantling the absolute myth of the 6-week bounce back. We looked at the 6 distinct layers of a C-section and the terrifying trade-offs obstetricians make to prevent catastrophic future hemorrhages.
And we broke down the mechanics of forceps
Mhm.
and the resulting nerve denervation.
Yeah, we explored the mandatory month-long waiting period where your immune system absolutely demands rest, right through to the thermal lasers and reconstructive surgeries used at the 1-year mark to finally give these women their quality of life back.
It really highlights that postpartum recovery is a marathon that begins rather than ends at the finish line of birth.
Exactly. And it requires immense patience, respect for cellular biology, and targeted, phase-appropriate medical care.
We hope this gave you a completely new perspective on what the human body is actually capable of and what it endures. But as we wrap up today's deep dive, our expert has a final thought for you to consider.
Here's the stark contradiction I want you to mull over. If the medical literature explicitly proves that deep tissue, fascia, and pelvic floor nerve recovery takes a minimum of 6 to 12 months,
Right.
and if the specialized medical community knows that advanced rehabilitation for birth injuries can't even safely begin until that biological timeline is passed,
Right.
why do our societal expectations, our cultural pressures, and our workplace maternity leave policies still treat the 6-week mark as the finish line?